webinar titled The Autism-Epilepsy Connection. During this session, you will receive information on epilepsy and the related complications that can occur in up to 40% of individuals with autism spectrum disorders. Epilepsy and autism can have common biological origins. So understanding the causes of epilepsy can give insight into the mechanisms of autism spectrum disorder. Since epilepsy can often be successfully treated, proper identification and diagnosis is essential, particularly for the clinically silent forms. While acknowledging the need for education around the specific topics such as today's presentation, the Family Support Center of New Jersey also knows that families have specific questions around their child's transition years. The Transition Matters website assists families and professionals in identifying resources to successfully transition your child or student with special needs to adulthood. Resources such as webinars, in-person workshops, and statewide and regional contact information are made available on this site. We encourage you to explore the site further and register for any upcoming sessions that may be of interest. Before we begin, let's take a moment to go over how you can participate during today's web event. Everyone has their own control panel in the upper right corner of their screen that looks similar to the one here. Use the orange arrow to open or hide your control panel. To listen to the webinar, you have two audio options to choose from, mic and speakers and telephone. If you can't hear well using your computer speakers, you can elect to use your telephone to listen to today's session. In order to maintain the best sound quality possible, all but the presenters will be muted throughout the webinar. If you have questions or comments, you can submit them using the questions panel. All questions will be collected and answered at the end of the webinar as long as time allows. At this time, we would like to introduce this afternoon's presenter, Dr. Mark Mintz.
And Dr. Mintz, I'm going to give the audience a brief introduction, a brief bio. So Dr. Mintz is President, CEO, and founder of the Center for Neurological and Neurodevelopmental Health, CNNH, and the Clinical Research Center of New Jersey, CRCNJ, and co-founder of Neurobilities, a 501c3 public charity. Dr. Mintz is quadruple board certified in neurology with special qualification in child neurology, neurodevelopmental disabilities, epilepsy, and pediatrics. Dr. Mintz is on the faculty of Rutgers New Jersey Medical School and has been on the faculties of the University of Pennsylvania School of Medicine and Rutgers Robert Wood Johnson Medical School at Camden. Dr. Mintz is widely published in medical literature, is on the editorial boards of peer-reviewed journals, and has been an invited lecturer at a number of national and international conferences. He functions as the principal investigator on a variety of original research grants, clinical trials, and other research studies. Dr. Mintz has been the protocol neurologist for National Pediatric AIDS clinical trials and has participated on an array of committees, task forces, and research projects of the National Institutes of Health, American Academy of Neurology, Child Neurology Society, and the New Jersey Governor's Council. Additionally, Dr. Mintz has served in the National Health Service Corps of the United States Public Health Service and has volunteered for medical relief missions in Romania and Russia. And without further ado, welcome, Dr. Mintz. We're going to go ahead and switch over the controls to your screen.
Okay, thank you. Thank you for inviting me. Today we're going to talk about the Autism-Epilepsy Connection, and you should be seeing these slides appropriately.
Yes, we do.
Okay. These are my disclosures. And as mentioned, the Center for Neurological and Neurodevelopmental Health is described here, and I invite you to visit our website for further information. So autism, although it's behaviorally and developmentally defined, it really is a very true neurobiological disorder of early brain development. The problem with autism as it stands right now is that the diagnosis doesn't depend upon the biological causes. And I will show you some information to suggest that really it's not fair to think about autism as a mental health disorder as it's presently classified. As many of you know, autism is quite prevalent. The national prevalence is high, but in New Jersey in particular, it's extremely high in the pediatric population. Almost 2% of children in New Jersey are diagnosed with an autism spectrum disorder. The epidemiology suggests that there is a higher incidence in males, a higher incidence in siblings, particularly if there are twins. Identical twins have a very high concordance, but even unidentical twins have a high concordance rate. And you see that autism rates seem to be similar across the globe and across cultures. So, you know, all this suggests that there are some unrealized issues with autism, but that there seems to be a biological prevalence. Otherwise, you would see differential rates across the globe, and the higher male incidence also and higher sibling incidence suggest biological causes, particularly genetic causes. Now, as I mentioned, the diagnosis of autism is presently contained within the Diagnostic and Statistical Manual, or DSM, version number 5. It's a manual of basically mental health disorders. And the newer version, the number 5 version, has changed the diagnostic paradigm somewhat and created a two-factor approach, that is, deficits in social communication and the presence of restricted interests and repetitive behaviors. So under the older diagnostic paradigms, we had subclassifications like Asperger disorder, and there's been some controversy that within the new diagnostic classification scheme, there's been a loss of such unique categories like Asperger disorder, and a lot of people are concerned that this may create a loss of services. But nevertheless, overall the change in the diagnostic scheme under the DSM-5 is to be a little bit sort of over-inclusive, or if you will, lumping into a single autism spectrum disorder diagnosis and then grading it from there. But again, the problem is that it doesn't recognize the biological causes. So basically, autism spectrum disorder diagnosis is really the final common pathway of these traits, these behavioral traits and developmental traits that are really from many, many different types of causes and mechanisms. And you can see there on the bottom that even a publication that analyzed the DSM-5 emphasized the need that we need to have biological meaningful subphenotypes. A phenotype is a description of an individual from a clinical standpoint and from a laboratory standpoint and everything that could feed into that. So an overall profile of an individual is their phenotype, and the biology, of course, is what might be causing it. And you know, a simple analogy I could give is something like cancer. You wouldn't think about cancer in terms of one large group, and therefore you wouldn't think about treatments of cancer. You would think about biologically meaningful subtypes of cancer, because the treatments of cancer, the diagnosis of cancer, will depend upon whether it's lung cancer or ovarian cancer or brain cancer. So the biologies are different, the diagnosis is different, the treatments are different. And I would say that, you know, entities like autism need to be thought of in the same context, that we need to understand it more from a biological perspective, not just from the external manifestations and symptoms. So again, the DSM-5 in general, and particularly for autism, there are a lot of pitfalls. That these criteria are very general, they're very nonspecific, they're very subjective and qualitative, so they're prone to a lot of error in diagnosis. And again, it ignores the biological causes and contributors to that problem. And it leads to very heterogeneous groups, so that when you're talking about autism spectrum disorders based upon DSM-5 criteria, from a biological perspective, these are a very neurobiologically diverse group. So that when you're talking about research that looks at, for example, treatment of autism, a lot of that is not going to make a lot of sense as we go forward and we understand the biological causes and contributors to autism. Because what's important, just like the analogy I gave with cancer, is to understand the biological cause and attack the biological cause rather than just to try to suppress external symptoms. So we really need to move from a diagnostic perspective to understanding these disorders like autism spectrum disorders from a biological perspective, or biological phenotyping, and also what I call clinical profiling, which is that overall measure, what you can actually measure a person can do. So autism really is not a mental health disorder. It is a very classic neurological disorder in many respects. So there are many, when you do an examination or you do testing, you find a lot of findings and signs and measurable aspects of problems within the central nervous system. The motor system is usually impaired in terms of coordination and planning and tone. Cerebellar functioning, which is posture and balance, is often impaired. The motor stereotypies are very, very classic for autism. That would be things like hand flapping and repetitive movements. In fact, it's part of the definition of autism spectrum disorders. Often you can see changes in head growth velocity, which is suggestive and somewhat analogous to brain growth. And there are various types of neurodevelopmental issues in the unfortunate individuals that pass on and their brains are examined. You can see very distinct pathological changes. During life, you can see changes on advanced radiological imaging technologies such as magnetic resonance imaging and others. The autonomic nervous system is often highly involved. That is your fight or flight response or your reaction to environmental stimulation, so that in individuals with autism, there's often a very exaggerated response. There's usually some sort of cognitive problem, intellectual problem, learning problem. And often, and of course the topic of today will be, there's often links to other types of disorders, neurological disorders such as epilepsy, which we'll talk more in depth today, and sleep disorders, and other problems in other organ systems such as the gastrointestinal system, problems with immunological function. And as part of autism, there's more often than not some form of a neuropsychiatric syndrome. So what are the biological causes of autism? Well, first you have to make sure that something's not mimicking autism. Hearing loss early on will cause problems in language acquisition and development and other problems in development and can look like autism, but if the hearing aspect is remediated, the symptoms and signs that were described as autism will tend to diminish or disappear. Intellectual disabilities and cognitive deficiency, now you can have autism and be intellectually disabled, but not all intellectual disabilities manifest with autism spectrum disorders, so you have to be a little bit careful about that. And also early on in development, there are just infants and children who have problems in language acquisition, and that impairment in communication can lead to other behavioral traits that can be misdiagnosed as autism. The other biological causes of autism, though, are in many cases a problem in early brain development, or what we call connectivity, or a problem the way the brain circuits connect to each other, which is called synaptogenesis. And this problem can be seen in intellectual disabilities, and this problem of brain connectivity is also a common biological cause and contributor to epilepsy syndromes. So we can begin to see that there's some commonality, there's some common ground, there's some common origin between epilepsy and autism. The other big area is genetics. There's been an explosion in the understanding of genetic variations and mutations that can lead not only to autism but also to epilepsy, and sometimes those genetic variations can be very similar and overlap. On the other hand, there may be environmental triggers both for autism as well as epilepsy, but in most cases there is probably some form of a genetic predisposition for the manifestation of autism, and it's that some sort of environmental aspect or trigger may have brought out either at an earlier time or may have been necessary to bring it out in the first place. So your genes are something that provides a marker of risk and susceptibility. So you could have a gene for various types of diseases and disorders. Doesn't necessarily mean you're going to have that problem, but maybe because of other genetic influences or maybe because of some factor in the environment, it triggers that gene to become more active. And what are called neurotransmitter disorders. Neurotransmitters are little chemical messenger systems within the brain. And these not only can be associated and causative of autism, but also overlap very highly with epilepsy. And all these factors can be made worse by inflammation. So the concept that inflammation may be in some way related to autism may be a primary cause, but also it may be exacerbating some underlying metabolic condition. Another major cause of the development of autism is adverse events that occur during fetal development. That includes infections, exposure to toxic substances, and also where the brain does not early lesions in the brain and other problems can lead to developmental problems in brain development, and the manifestations might be, in some cases, autism as well as other neurodevelopmental issues, and also epilepsy again. There are other possible biological causes of autism listed here, such as toxins, immunological aspects, gastrointestinal issues, infectious viral infections, and hormonal changes. And in some cases, there is some very strong evidence for some of these mechanisms. The other big area, of course, in many individuals with autism is that we don't have an identifiable biological cause or contributor. And in those particular situations, it may be that we just haven't identified it as yet. And this is particularly true in the area of genetics, where 10 years ago we might be able to diagnose less than, be able to identify genetic cause in less than 10%. The yields are much higher, 20, 30% higher, depending on the situation. So the findings of the biological causes in autism are growing, and again, there's a lot of overlap with epilepsy. I just want to mention that there's been a lot of environmental associations that have been purported to cause autism, but we have to be careful that association is not necessarily causation. So some of these environmental associations are various food sensitivities, particularly gluten, exposure to toxins like heavy metals, pesticides, industrial chemicals, exposure to alcohol, smoking, and drugs, particularly in terms of the fetus, fetal infections, fetal exposure to other maternal factors, problems in the pregnant female. Vaccines have been one big area, though. There's very strong evidence to suggest that vaccines are not causative of autism in a population sense. There have been occasional rare reports that really, when you look at them carefully, those individuals had pre-existing and identifiable, in some cases, metabolic disorders that were just exacerbated or brought out by the stress of a vaccine. So those are individuals that probably would have had eventual manifestation of autism anyway, and in some cases it might just be coincident. Parental age recently has been an issue with older mothers. There's always been a higher risk of genetic problems, but now there's been some reports that in older fathers there may be a higher risk of having someone with autism. It may make some sense from the standpoint as people age. There's important variations and mutations that might lead to problems in the offspring. But with all these, again, you have to be very careful to suggest that just because there's an association, it's not always causative. Particularly when you have an entity like autism, which is in epidemic proportions right now, and some of these other associations and exposures, which are also quite common. So if you put something that is relatively common with something that's relatively common, the chance of coincidence of an association is high, and it takes a lot more research and investigation to understand which of these factors are truly causative rather than just associated. So when it comes to autism spectrum disorders, we have to understand the individual from a biological perspective through this process of biological phenotyping. For co-occurring conditions such as sleep problems, problems with the autonomic nervous system, which is this over-exaggerated response to the environment or to external stimulation, gastrointestinal issues, hormonal problems, problems of nutrition, that is, cofactors and elemental aspects like vitamins and minerals, inflammatory, immunological, infectious problems, and various neuropsychiatric disorders. What does the individual look like from a neuropsychological perspective? What about from a behavioral perspective, particularly the functional behavioral analysis to try to tease out maladaptive behaviors, whether or not they are occurring for a biological reason or whether there's some identifiable functional cause, such as for attention or trying to escape from doing something. Various laboratory assessments can be done to and then also neuroimaging studies, for example, magnetic resonance imaging can tell you a lot about the structure of the brain, maybe tell you about congenital problems, and also can interplay with genetic factors or acquired problems. And there is a number of functional neuroimaging studies as well that can tell you a little bit more about how the brain functions. Now, shifting now for gears over to epilepsy, which is, we're looking again at the autism epilepsy condition and trying to define epilepsy. Epilepsy is quite a prevalent issue within the United States, as you can see here. In 2008, an estimate of 2.7 million Americans are affected by epilepsy, and that equates to about 1 in 100 adults. And it's a very heavy because it's been somewhat unresting since it's never been, but still a lot of society doesn't recognize epilepsy as a disease state, and also there's a lot of problems in funding mechanisms to try to provide services for individuals with epilepsy. But epilepsy, it can be very disabling, as many of you might know. Quality of life is a big issue. In children and adolescents, it's often when the first seizure occurs, and in most cases of people with epilepsy, the first seizure occurs under 20 years of age. But nevertheless, epilepsy for most individuals is a lifespan disorder. So we have to start thinking about this not just as a pediatric disorder, but as more of a lifespan disorder. And the features in pediatrics are somewhat different than adults, so we have to look at the pediatric population a little bit different than the adults. But the impacts are the same.
Dr. Mintz, I apologize for interrupting. I'm hoping that you can hear me.
Yes.
Dr. Mintz, if you could, and I do apologize to everyone in attendance this afternoon, if you could click on your audio button and click on telephone and call in using the telephone. There is still some audio issues happening with GoToWebinar, and I'm hoping that that's going to help clear up the situation.
Okay.
So again, I do apologize for the delay and the interruption.
Okay, so I'll telephone in now. Okay.
Yep, just click on audio, and if you click on telephone, it's going to give you a number to dial in. And if all of our attendees would just hold for a minute, you should be reconnected back into the session. So I do apologize. And Dr. Mintz, if you're having any trouble identifying the phone number or the button to click, just let me know and I'll help in any way that we can.
Hello?
Dr. Mintz, did you call in using the telephone?
Yes, I'm on telephone.
Oh, perfect. Okay. And again, everyone, I apologize. I know that the audio hasn't been as clear as we were hoping, so I'm hoping that this is going to help the situation. Dr. Mintz, if you would proceed. Thank you.
Okay. So as many know, epilepsy is a problem of abnormal and aberrant electrical activity of the brain, as you can see here. But epilepsy, in some analogies to autism, the manifestations of epilepsy or the actual seizures are really the final common pathway of various biological mechanisms and triggers. So I would suggest that epilepsy also, in a way, can be thought of as a spectrum disorder. There are those that are manifesting seizures that are observable, and there are various types of seizures. But there are other individuals that are manifesting electrical changes in the brain that may not be causing external observable seizures or maybe occurring at such a low rate that nobody can detect them, but yet are still causing a lot of problems. They might be causing a lot of problems of brain function. Recent change, the ILAE, as the International League Against Epilepsy Task Force in 2014, changed what they felt should be a more operational or practical definition of epilepsy, that it's a disease of the brain, not just a disorder. Similar as past definitions, it's defined as having 2 unprovoked seizures more than 24 hours apart, or they changed it to you could have 1 seizure, again, these are observable seizures, with a high risk for a second seizure, such as maybe a very abnormal EEG. And that would be sufficient just with 1 seizure to diagnose epilepsy rather than just to wait for the second seizure. Or someone fits into what's called an epilepsy syndrome, which is a cluster of symptoms and signs, maybe a certain age, a certain seizure type, maybe a genetic marker, and that you fit into that epilepsy syndrome, and that's sufficient to diagnose epilepsy, even though you've had maybe only 1 seizure. The other change in the definition has been to consider epilepsy resolved. You could actually lose a diagnosis of epilepsy if you have not had a seizure for at least 10 years, and 5 of those years was without seizure medicines. Or if you outgrew the epilepsy syndrome age limit. So if there's a certain epilepsy syndrome that usually occurs only in very young ages, for example, once you get older and you no longer have any risk factors for epilepsy, they can take that diagnosis away. And this is very important, obviously, particularly in adults and aspects of driving and insurance and other issues, whether you have to report that you still have a diagnosis of epilepsy or not. But similar to autism, epilepsy as we go forward is also going to depend upon the biological causes in terms of how to define it. In particular, there's been a very rapid advances in the area of genetics, and that there are many, many different genes that are now associated with epilepsy. These genes may, again, present a risk or susceptibility factor, but inform much about epilepsy in terms of not just the causation, but also maybe different treatment choices. In particular, maybe a certain medication may be more appropriate for a certain type of genetic finding or genetic change or variation. Also, epilepsy is defined by the neurophysiological findings, particularly electroencephalographic or EEG findings, and various forms of structural tests such as MRI and imaging studies, particularly functional imaging studies, and other biological markers such as inflammatory problems, neurotransmitter disorders, and metabolic problems. So again, we could phenotype, if you will, just like we do with autism, people with epilepsy in terms of their seizure type, which is observed, but also that which can be seen just electrically on EEG. And also look at other factors that are associated with it, such as some sort of neurodevelopmental problem, intellectual issues, autism spectrum disorders, head size, which is micro or small, or macro, which is large, or hypotonia, which is low tone, or whether epilepsy may be more from an acquired phenomena, such as a brain injury, and also look at other associated problems related to epilepsy or the treatments and or unrelated to them, and also look at the neuropsychological profile. So again, just like we did with autism, you could create this biological clinical profile. And this may lead to specific therapies that are targeted to biological mechanisms and causative factors rather than just try to suppress symptoms, which are the seizures, with a goal to focus on quality of life. So the causes of epilepsy, like mentioned, are structural and metabolic in many cases. So in many of these situations, it's more of an acquired phenomena, such as a stroke or a brain injury. But in many cases, there's a genetic risk and susceptibility, and you might have 2 hits. You might have a genetic pre-existing risk that is compounded by some acquired phenomena like a brain injury, and it might make you more susceptible to developing recurrent seizures or epilepsy. There's still many epilepsies, if you will, of unknown cause, but again, these are presumed to be genetic, metabolic, or other biological factors that just haven't been determined yet. And again, just like autism, this group is shrinking as we have more knowledge about genetics and other biological measurements that can determine causes and contributors to epilepsy. Epilepsy, like autism, could also form these syndromes, if you will, that are based upon various clinical and other factors. So, if you can see, we talked about autism, we talked about epilepsy, and there's this developing connection between the two. If you look at the Epilepsy-Autism Connection, there's a very, very high prevalence of epilepsy and autism. Over the course of a lifetime, maybe as high as 67%, and these are people who've had an observable seizure at some point in their life. If you look at individuals who might have EEG changes or other abnormalities and have not yet established themselves as having an observable seizure, that number could get even higher. And the rationale for this is quite obvious, if based upon what we just discussed, is that in many cases there seems to be a common association between the two, because the causes of epilepsy and the causes of autism can be similar. They can be genetic, they can be developmental, they can be from a problem with brain development and connectivity. It's important to understand the concept of epilepsy within the context of autism, because epilepsy will increase the risk of mortality in autism, so it's important to recognize epilepsy. Sometimes epilepsy can be difficult to recognize in someone with autism, with severe autism, who may have a lot of associated maladaptive behavior, so subtle seizures may be missed. So it's very important to identify this. And epilepsy in some cases may be associated with language regression. So again, there's an overlap. Epileptogenesis is the process of the biological process leading to epilepsy. So again, there can be symptomatic causes, acquired structural problems from a stroke or a previous infection or brain injury or a tumor. Developmental issues, a common cause of difficult to control and treat epilepsy, is what's called cortical dysplasia, which is an area of the brain and brain cells or neurons which just don't form properly, but can cause a very irritable area of electrical activity that could lead to autism, that could lead to epilepsy. Various forms of metabolic disorders. Prolonged and recurrent seizures can lead or beget more problems in the brain, leading to more seizures, if you will. And then there's the other area, the non-acquired form, the non-symptomatic form, that is from some sort of genetic predisposition that could lead to issues and problems within the brain that could cause epilepsy and or other neurodevelopmental disorders, including autism. What are called channelopathies, which is the ability to transport sodium, potassium, calcium, magnesium through these different pathways that are called channels, and sometimes if those channels are not functioning well, that can lead to all types of problems with brain function, including epilepsy, including autism. And this issue of connectivity, how the brain circuits connect with each other, and this disorganization of connectivity can lead to autism, can lead to epilepsy. So again, there's some very common pathological and genetic substrates. And by understanding the causes of epilepsy, by understanding the causes of autism and how they overlap, that could lead to a lot of clues in how we could target treatments for the future, not only to treat these disorders from a symptomatic viewpoint, but possibly even alter disease. So I mentioned there's a lot of epilepsy genes. There's a lot of genes that have been associated with epilepsy. Some of them are listed here, but the list is growing. If you look at actually what are called not just genes, but also the exomes, the coding regions of these genes, and there could be multiple areas within each gene that could cause a problem. Particularly, these channelopathies are very important in epilepsy: calcium, potassium, sodium, magnesium. Receptors, what's called the GABA receptor, you may have heard of. That's also a target for a lot of anti-epileptic drugs. The NMDA receptor, which may be also involved in cognition and is often a target also in entities like Alzheimer's. Some other types of receptors, and a whole slew of other genes, some of which are involved in the production of energy within the cell, or mitochondrial function, if you will. So many different associations. And again, a lot of these genes are also been implicated in autism. So again, this common biological origin between the two. Our group recently reported our approaches to genotype-phenotype correlations, or in other words, looking at people's genetic sequences or DNA sequences, what are called exome sequences, particularly focusing on genes involved in energy production within a cell, which often affects what are called mitochondrial functioning. Mitochondria are little energy factories within every cell, including brain cells, and channelopathies, which again is the ability to transport sodium, potassium, calcium, and magnesium both in and out of the cell as well as within the cell itself. And we looked at people with neuropsychiatric disorders such as anxiety and obsessive compulsive disorder and those with autism spectrum disorders. Most of them had this profile of over-responsivity to the environment, to environmental stimulation, what we call autonomic over-responsivity, which is, again, something that stimulates someone and they get very sweaty or diaphoretic, tremulous, sort of a nervous movement, akathisia, emesis, which is vomiting, flushing of the face and other areas, fast heart rate. Maybe they have other issues like migraine and problems with sleeping in normal patterns. And so all but one had that sort of clinical profile. And we found a lot of variants in the autism spectrum disorder population. 44% had gene variations that were likely causative, and either likely causative or more definitely causative and contributory to their condition, which is a relatively high rate for a diagnostic test. Again, genetic testing for autism 10 years ago was less than 10% in terms of being able to identify a genetic problem or variation. So very high rates. And not only were these high rates, but a lot of these variants were considered actionable. And actionable means, again, a potential treatment intervention that might be suggested by the genetic variation, maybe additional diagnostic testing, the presumption of a biological cause or contributor, which might help to stop the diagnostic journey, if you will. And a lot of people are constantly, and for many years, searching for reasons why they're having autism, or in some cases epilepsy, and by understanding the genetic makeup, that might stop that journey, which might involve a lot of expensive and in some cases unnecessary tests. It might also alert to other problems. Some of these genetic markers can sometimes say, well, there's a high risk for a cardiac rhythm problem, and that might proactively provide some evidence to be very proactive to try to prevent a disaster occurring later on. And some of these genetic markers might not only tell you about medications to use, but also medications to avoid. So it can be very important. So when do you suspect epilepsy in those individuals with autism? Well, basically, since the rates are so high, we'd really say, in a sense, consider in all children, but especially if there's something like an autistic regression or a loss of developmental skills that were previously acquired. Anytime you have some clinical aspects of epilepsy, particularly if it was before the development of autism, a history of a status epilepticus, which is a very prolonged seizure event, and also to consider in any child who has identifiable or suspected metabolic or genetic problem. If there are symptoms of epilepsy, I would definitely consider epilepsy as associated with the autism. That is, unresponsive states, impairment of consciousness, excessive inattentiveness. And again, people with autism can be inattentive, but it really is sort of a clinical flavor to that. Syncope, which is fainting. And if there's a lot of motor movements and repetitive movements, sometimes that can, again, just be a normal repetitive movement of autism, but sometimes if it is very repetitive, and it could represent a movement of a seizure. Sleep disruption would be a clue to possible epilepsy associated with autism. Neuropsychological changes and decline. Psychoses or psychotic or delusional types behaviors can be from a seizure itself, can cause psychosis, but also when someone is not having a seizure, just the changes that occur in the brain from epilepsy can lead to psychosis in between seizure episodes. And in some cases that might require EEG to try to correlate these events to see if there's some association with electrical activity of the brain and psychotic-like behaviors. Anytime there's unexplained paroxysmal or intermittent events or symptoms, and again, we're leading to this concept of what I called before the epilepsy spectrum disorders. That is, there are people who have observable seizures and have defined epilepsy, but there may be others not classically defined as epilepsy, but are having electrical changes of the brain or subclinical spikes that is causing neuropsychological changes or behavioral problems. and not, maybe at some point they will develop an observable seizure, but maybe not. And those that are developing what are called subclinical seizures, which are actual seizures, but they're happening so quickly or briefly that nobody's noticing them. Autism has associated epileptic syndromes, what we call epileptic encephalopathies, which cause clinical impairment associated with EEG changes, different types of seizures, and at different types of ages. In many cases, these are causative, or in some cases, they may be what's called an epiphenomenon, which is that you would have developed autism anyway, but also associated with it, you're developing some epilepsy complications or electrical changes. The causes of these syndromes in some cases can be structural problems of the brain. In particular, metabolic problems and genetic problems are very important in these type of syndromes. They can be associated with regression. So in other words, regression is the loss of previously acquired developmental skills and abilities. So an autistic epileptic regression is somebody with autism, regression, and identified epilepsy. But then there are those who have an autistic regression without identifiable seizure events, but their EEG is very abnormal. So this is regression without epilepsy. Some classic epilepsy syndromes you may or may not have heard of is things like infantile spasms or West syndrome, which occurs in infancy and associated with a very abnormal EEG pattern called hypsarrhythmia. These seizures that they have are these spasms where the body tends to flex, the legs, the arms, and the head and the chest tend to come together, and it occurs repetitively and in clusters. There are other forms. Sometimes it could just be very subtle, like a head drop. But there could be very frank regression in development. And the causes are different again, like many of these situations. Again, it's important to define the biological cause because there are more symptomatic causes. There may be a structural problem of the brain, like a previous stroke or some other issue. In many cases, it's not unidentifiable or cryptogenic, and that, again, is presumed to be most likely a metabolic cause. And then there are genetic causes, particularly tuberous sclerosis is highly associated with infantile spasms. Treatment is very important in these disorders because in some cases you can actually normalize the situation and get full recovery, but unfortunately in some individual infantile spasms there will be a more permanent problem with intellectual issues and developmental problems, and in some cases development of autism. Another very difficult to control epilepsy syndrome called Lennox-Gastaut often has autism as part of its manifestations. Lennox-Gastaut doesn't mandate you will develop autism, but you often see epilepsy and severe autism associated with Lennox-Gastaut syndrome. These are individuals with multiple seizure types, particularly one common seizure type is the drop seizure, a sudden loss of tone and dropping to the ground. Cognitive impairment is very, very big feature of Lennox-Gastaut, and partially because the seizures are so difficult to control in many cases. Some of the issues with Lennox-Gastaut in some situations it's acquired from a malformation of the brain, a brain injury, a previous infection. But in 30%, it's again this concept of idiopathic where we haven't determined the cause. And in those situations, it's probably some sort of as yet unidentified genetic cause. Landau-Kleffner syndrome you may have heard of as well. This is associated with language regression that can be very, very abrupt. It could be a young child who may be speaking in full sentences and suddenly, and over a short period of time, loses that ability to communicate and may become actually nonverbal. It usually occurs again in the first decade in children. They don't usually have clinical seizures, but their EEGs are very abnormal. Their EEGs look like someone who has recurrent seizures, and particularly when they fall asleep. The EEG gets very, very active. So they have this very active EEG that often would be associated with somebody having an active seizure, but clinically they're not manifesting any externally observable seizure. And the associated problems with that in a similar sense is these things called CSWS and ESES. In some of these situations, there'll be clinical seizure and EEG findings, but the EEG gets very abnormal when they fall asleep. 85% during sleep will have, 85% of their sleep will be this very recurrent electrical discharge called spike and wave. But yet, when they're actually having this spike and wave activity, there's no observable clinical seizure in many cases. And again, it's often associated with language regression and autism syndromes. again, this just reiterates all the different findings. So here you see an EEG, and you don't really have to understand how to read EEGs just to see the differences in the three vertical columns. The first column is a relatively quiet, normal EEG. The second column is where the child's starting to get a little drowsy, and you can see a little blip there just past the middle of the column. And the third column is where the individual fell asleep, and you can see that if you compare that to the first column, you can see a lot of activity, what's called spike and slow wave discharges. And yet this individual was not having observable seizures during this EEG, but did develop a autism-like syndrome. So when someone presents with seizures, the question is, how to evaluate that. First, you have to understand and sort of classify what was the description of the seizure and what type it was. Did it occur from a focal area, or did it occur sort of what are called primarily generalized all at once? Was it from some sort of provoked mechanism, like a head trauma, concussion, or did it just occur spontaneously for no reason or unprovoked? And again with seizures, the issue really is to try to identify what is the mechanism that caused that seizure. You need to do a good examination, both neurologically as well as the rest of the body, and try to identify, again, any things that might have contributed or caused that seizure. And the EEG is very important. The EEG provides some aspects of where electrical activity is occurring within the brain, how often it's occurring, or what's called spike burden. And sometimes you're even fortunate enough to have the EEG going at the time of a clinical seizure event, and then you can have a direct correlation between the electrical activity of the brain and the seizure event itself, or what they call electroclinical correlation. And then we also try to take the seizure, the age of the patient, other factors, and other clinical features, and say, does this individual fit into a known and identified and previously reported seizure syndrome? Additional diagnostic studies are usually necessary in the evaluation of seizures. That might include neuroimaging, such as magnetic resonance imaging, MRI, which provides a structural picture of the brain. Electrocardiogram is often ignored or neglected, but you have to remember that cardiac problems, particularly rhythm problems of the heart, can present actually with a seizure, because of a change in heart rhythm could lead to alterations in blood flow to the brain, and that can cause problems within the brain, including seizures. Laboratory studies are important to look particularly at just the overall levels of sodium and other aspects of blood parameters to make sure everything is normal, and again to see whether the situation was provoked by something rather than just occurred spontaneously. And in today's age, you really have to strongly consider genetic evaluations, particularly targeted exome DNA sequencing, which looks at DNA sequences and genetic variations and mutations that might be associated with epilepsy. Another approach is what's called chromosomal microarray, which is another way to look at your genetic material, your DNA, looking for areas that may be deleted or missing, or duplications or extra pieces of DNA, which also can be associated with problems. And then, of course, there's a decision on treatment, weighing the risks and benefits of the treatment versus controlling the seizures, and different treatment strategies include medications as well as non-pharmacological therapies such as dietary involvement changes and surgeries and neuromodulation, which we'll take a look at. But more importantly, obviously, is to take necessary precautions. As someone who has seizures, in most cases, the seizures themselves are not as harmful as the situations they occur in. So obviously, if someone loses consciousness while swimming, they have the risk of drowning. So you just need to take necessary precautions as well. We mentioned, when to consider epilepsy in those with autism. Now the question is, what about autism and measuring seizures through an EEG, which could be very difficult in individuals with behavioral challenges. So who needs this study? The question is about sleep. We talked about how sleep sometimes brings out EEG changes that you might not see in the awake state. And how do you accomplish this in these behaviorally challenged individuals? Well, a lot of people use sedation, but sedation will change and alter the electrical activity of the brain. So the issue is, are you really benefiting, even though you might sedate somebody and get the study? Is that study really valid or worth much to you from a clinical standpoint? and then other people use restraint and behaviorally challenged individuals. That could obviously make things worse. It could make it difficult the next time you want to do an EEG because they do remember what a traumatic experience they had. So there are some other ways to accomplish this. Traditional EEG really hasn't changed for 60 years, and you can see here how this is commonly done by placing electrodes onto a head, first having to scrape the scalp to establish an electrical connection with the measuring devices, which are electrodes using various types of glues and pastes. And in all that, it takes about 20 minutes to apply 20 electrodes. This is some of the aspects of restraint, which can be very traumatic for those with autism who are nonverbal and don't understand what's happening to them. And it creates more anxiety and a very poor patient experience. And it deteriorates the quality of the EEG if somebody is fighting and moving and not cooperating. So there is a dense array EEG technologies you can see here that utilizing these sensor nets. This is a 128 channel net, so compared to 20 channels, it's 6 to 7 times the number of electrodes, and yet this net can be placed on within minutes. You could put on this 128 electrode net within a few minutes. They use little sponges that are soaked in salt water or saline, so there's no glue or paste. There's no need to scrape the scalp. And I would say that the EEG still is a very, very important study. MRI is a very high-level technology, but it only provides a sort of static or structural image of the brain, where EEG is still the only test that we have that measures neuronal activity or brain cell activity in real time. It's a direct measurement of brain cell activity, whereas some of the other imaging modalities you might have heard of, like functional MRI, measure blood flow and imply brain activity. So you can see here a dense array study provides a lot more information. That little blue circle is a focus of negative or spike activity, which you could also see on the right, the little spikes. So even if you lost a few electrodes in this situation, you still have a lot of information, but it uses what's called dipole modeling to really localize the source of the electrical activity, which could actually, with some software applications, be placed within the MRI, and you can see the actual electrical source in the two-dimensional image of an MRI in various aspects. So it's very good for localizing the source. You could also measure changes over time. MS is for milliseconds, so 411 milliseconds is still less than half a second. So you can see how electrical activity propagates through the brain. You may have heard of magnetoencephalography, or MEG, and this is the apparatus that's used for that. It is a very high technology and very good for source localization, but as you can imagine, very difficult to perform on behaviorally challenged individuals as they have to stay still within this apparatus. So it can't be done in very young children, and it can't be done on behaviorally challenged individuals. So I'll give you some examples. This is an 18-year-old that came to us with a diagnosis of autism and epilepsy and never had an EEG in her life. And the management questions really were, does she still need her anti-epileptics drugs, and does she have this concept of ESUS? So we put this individual through a desensitization protocol that we have with various positive reinforcements, and the net that we placed on her head actually became a positive reinforcement. She actually was requesting it. The EEG was very important to obtain because there was a lot of abnormalities, but we did not identify ESUS, so that really changed management. That's the little spikes in the blue circle, and this is what it looked like on the MRI. So we looked at some of the EEG studies we've done here at CNNH, and in individuals with behavioral challenges, 11 to 49, this was over a 5-year span, we do all our studies without sedation or restraint, and we were able to get 98% on the first attempt without sedation or restraint. Of the ones that were unable to be done on the first attempt, we offer a desensitization protocol, which is a form of gradual and repeated exposure and familiarization with not only the sensor net, but the whole EEG process. And this is done with our behavioral specialists and sometimes even our creative arts team. And we were able to accomplish it in 8. The other 10 decided not to proceed with the desensitization process. So you can get EEG in very behaviorally challenged individuals without sedation or without restraint. Again, I mentioned before, sometimes you could have electrical changes without clinical events, what we call subclinical epileptiform discharges or subclinical spikes. And again, this goes into this concept of epilepsy spectrum issues. I mentioned some of the disorders that have been described that have these spikes without clinical changes. So we looked at that as well in a number of areas, and so our hypothesis is that you can have EEG changes that are very, very significant and can also affect management without having clinical seizure events. So in 2009, this is not an autism group, but these were individuals with ADHD and learning problems who had no known seizures, and it was a prospective study. And then the majority of individuals, these were 6 individuals with spikes on EEG. They had identifiable neuropsychological changes, particularly reduction in working memory, and we were able to reverse that in 4 of them by suppressing their spikes with a medication called levetiracetam, with improvement in the working memory and also improvement in behavioral in some individuals. And that was a published study, as you could see there, in 2009. And we recently reviewed and presented an analysis of our digital dense array EEG recordings between 2010 and 2014 in various individuals and identified how many had subclinical spikes. So if you look at individuals who presented with seizure-like problems, as you might expect, there was a high level, 53% of abnormalities on the EEG. But if you look at individuals with autism spectrum disorders without known seizures, without known epilepsy, 28% had an abnormal EEG, ADHD 14%, again without known epilepsy, psychiatric disorders 19%, and down the line. So again, this issue that, and of those individuals with subclinical, unexpected subclinical spikes, almost half of them had a structural change on the MRI. So the ones that did go to MRI was 50, and about half of them had some change. So the subclinical spike helped to determine who required further studies like an imaging study, and also had informed us about various treatment aspects based upon our previous paper in 2009, that in some cases suppression of these subclinical spikes might improve function. So again, EEG is an important imaging tool, just like you talk about MRI. It's a direct real-time measurement of neuronal function. It's a tool that's very important in epilepsy, but also maybe a tool, it is an important tool overall in assessing brain function in many different situations. So again, a couple of examples: a 4-year-old female, diagnosis of a autism spectrum disorder under the old paradigm PDD. No history of seizures, but our dense array EEG found a lot of spike activity, or what we call subclinical spikes. That's what it looks like under the blue circle there, and another source on the left blue circle there. And this was a 6-year-old female who had a history that suggested clinical seizures. Her eyes would roll vertically upward. She had an outside EEG using the conventional system, the 20 channel, that was noted to be normal. We brought her in here, but the EEG really probably was poor quality because she didn't cooperate very well. We put her through a desensitization profile. We were able to get a good EEG. It had a lot of spikes. Again, that previous normal one, there's the spikes there, and on the MRI. Started her on levetiracetam or Keppra. We were able to achieve complete spike suppression, and there was improvement in her communication, social awareness, and interaction. Here's an 11-year-old with developmental delays of various types. At 5 years of age, was diagnosed with the autism spectrum disorder. At 9 years of age, had episodes of staring, and again, from on the outside, had a EEG that was reported as normal. Was being treated with a lot of different psychiatric medications. Our assessment, again, this sort of clinical biological profiling, found a lot of EEG abnormalities, a genetic abnormality called an XXY problem, or Klinefelter syndrome, and this individual also had some hair pulling or trichotillomania. So this approach to clinical biological profiling changed the management in this individual. We were able to target medications to the seizure type phenomena, to the behavioral phenomena, trichotillomania, and we also got them involved in some social skill development. And just to wrap up, associated with epilepsy are also a lot of psychiatric disorders, but you also see these similar issues in autism spectrum disorder. So again, there's a lot of overlap in the co-occurring conditions, both in epilepsy and in autism. There is also this concept of forced normalizations. Many of you might have experienced this concept, maybe with your children or family members, where individuals will have either epilepsy itself or abnormal EEGs without known seizures and get treated for that with anti-epileptic drugs. The spikes diminish or the seizures lessen, but the behavior worsens. This is a concept that was noted way back in the mid and early 20th century, where individuals were institutionalized, were getting, at the time, the only available anti-epileptic drug, phenobarbital, and were becoming psychotic. And a lot of people attributed it to the side effect of the medication. In some cases, that possibly was the case. But it is a phenomena that as the EEG normalizes, behaviors can worsen, sometimes even to the point of frank psychosis. And it's sort of the concept that if you suppress the seizure or under electrical activity, the brain becomes a little more functional, and therefore, behaviors can emerge, and sometimes these behaviors are not very favorable in developmentally impaired individuals. So overall, epilepsy and autism, it's an evolving, both of them are evolving, if you will, into sort of spectrum disorders. That there's many, many different biological causes and contributors, both to epilepsy and autism, some of which overlap. And the understanding in each area will help to understand how to treat both autism and epilepsy in much better ways. And the approach to epilepsy and the approach to autism in terms of diagnostics, they can overlap, particularly in the area of genetics. And EEG, there are sort of patient-friendly technologies. You can accomplish EEGs even in difficult populations like autism. And also you need to consider this concept not just of obvious epilepsy in those with individuals with autism, but also those that might be experiencing very subclinical approaches to epilepsy or subclinical spikes, if you will, without observable seizure events. And just to mention, we have a ongoing study now where we're looking at genotype-phenotype correlations in autism. If anybody's interested, you could just contact through the information that's listed here. This concept of trying to see what genetic variations and changes might be common and might be causative or contributor to our autism, but we're looking at individuals who have autism associated with epilepsy and intellectual disability. So I'll take any questions.
Dr. Mintz, it's Melanie. Thank you again for all the information that you were able to share this afternoon. We do have quite a few questions coming in. Some of them are very specific and personal, so we are going to try to generalize some of the questions as much as we can. So the first question is, how do you decide what medications or treatment will be effective for someone who is nonverbal and an adult with autism experiencing grand mal seizures? And also, in general, what are the best medications available currently for epilepsy? Dr. Mintz?
Yes.
Were you able to hear my question?
No, I did not hear your question.
Oh, I apologize. Again, I do want to thank you for sharing all the information that you were able to present this afternoon, and we are grateful. The first question is, how do you decide what medications and treatment will be effective for someone who is nonverbal and has autism and is experiencing grand mal seizures? And also, are there medications that you feel work best for treating someone with epilepsy?
So we're entering an age of what's termed personalized medicine. Some other analogous terms are things like precision medicine. But the concept of personalized medicine is to say that you can't just any longer talk about broad terms like autism or epilepsy and say there's a treatment for that. It really has to be personalized. So it depends on a lot of different factors for that individual. So the first step is really to understand the individual from a biological and clinical perspective. When it comes to somebody with autism and epilepsy or generalized epilepsy, it's important to know what the EEG looks like. It's important to know what the laboratory tests look like, their psychological function. And in today's day and age, it's very, very important to get some genetic information as well. Because not only might it tell you what treatments might be more beneficial and might be more efficacious, but also it might tell you what may make things worse. So, for example, there's a common genetic variation in some forms of epilepsy associated with autism called SCN1A. It can cause Dravet syndrome and other problems. In that, there's some exciting research in that area to suggest that cannabidiol might be useful. That's sort of the derivative of marijuana that a lot of people have been reading about. But more importantly, there are certain anti-epileptic drugs that are what are called sodium channel blockers, like lamotrigine or Lamictal, that might actually make things worse and need to be avoided. So it's important to understand all the biological factors and really, create these sort of biological clinical profiles, and rather than and then also there's also the concept of what's called pharmacogenomics, which are genes that are involved in medication metabolism, to see which medications might be more favorable for an individual. And going forward, all of us are eventually going to be taking that approach to see, rather than just taking a lot of the guesswork out of just trying medications and seeing what works, we could try to choose medications with a much more educational approach based upon understanding the pharmacogenomics, the overall genetic profile that might be causes of the epilepsy and/or autism, and other laboratory and clinical factors. So in answer to that question, it's difficult to say. It really depends on so many different factors, but I would say that it really needs to be personalized. There are no real broad recommendations. And then again, from there, even though you have all that information, nature is such that it doesn't always follow the rules. And for individuals, you still have to continue to monitor and see, even though it may look like a certain approach is favorable, it might not turn out to be that way.
Thank you very much. So the next question is, what causes epilepsy to occur in adulthood, and can it be brought on by childbirth?
So in adults, if they've had their first seizure as an adult, often in adults you have to be very careful and look for identifiable causes that might not necessarily be in the brain, such as cardiac issues or other problems within the rest of the body that might affect the brain to a point where it causes a seizure. The other area in adults that's a big area is traumatic brain injury, and sometimes that could be at a very low level, repeated concussions. A lot of our veterans that are coming back from Afghanistan and Iraq have had low-level traumatic brain injuries sufficient to cause not just psychiatric issues, but also, in some cases, to cause epilepsy. But even in adults, you could have a genetic predisposition for epilepsy that doesn't show its face until you become an adult. So genetic factors also need some consideration.
Wonderful. And can hormones cause a tonic-clonic seizure for someone who is in their teenage years? So
the concept of puberty and adolescence, does that change epilepsy? It's quite interesting. What I usually say is it's just so unpredictable that if you have known epilepsy and you're entering into puberty and adolescence, in some cases seizures and epilepsy will diminish and disappear. In some cases it will stay the same, and in some cases it will worsen. It's just so unpredictable. We don't really know enough of the influence of puberty and adolescence to say which individuals are going to get better or worse. It may be a lot more clear in the near future as we understand genetics better. As far as those that have their first seizure in adolescence, again, if you have an underlying predisposition or a lower threshold to develop a clinical seizure, either because for example, your EEG already shows electrical changes, or there's some genetic factor that puts you at risk, the stresses of adolescence through puberty and hormonal change could be enough in certain situations to sort of push you over the edge and have your first seizure.
Great. And should a dense array EEG be done on someone who is on seizure medication?
Can you repeat that? That broke up.
Sure. A dense array EEG, should that be done on someone who is already on seizure medication?
So a dense array EEG is an EEG. It's just a better form, a more advanced technology. So, for example, you have MRI machines that are older and not as high definition, if you will, and the newer ones have much higher definition. So a dense array EEG is, in a sense, a high definition form of an EEG. But that little net device I showed you makes it a lot easier actually to do on those that are behavioral challenged. So in general, I mean, the decision to have an EEG is not so much whether to have a denser EEG. The question is if the clinical situation is such that you need an EEG, and there's many different reasons why somebody should have an EEG, then dense array EEG is an option. It's a more comfortable option, and it provides a lot more data information than conventional EEG.
Great. And can you share the net that you were speaking of for the EEG? We've had a few questions in regards to the different types of EEG. We've had short-term, overnight stays, in-home EEGs. Can that net be used in any of those fashions?
So the one I showed is a particular manufacturer. There are I'm not sure how many manufacturers that have developed some sort of caps. You'll see sometimes you'll see caps, and you'll see something called dry electrodes and wet electrodes. So it's different forms, and there are different types of nets that are applicable to different situations. The one I showed you is a more in-office situation. There are ones that are designed for the hospital for longer-term studies, 24, 48-hour studies, and there are now some that are being designed for home studies. So there are different applications. There are different types of nets available for different types of applications, both in the office, hospital, or in the home.
Wonderful. And I'm going to ask one more question if we could. We actually have an attendee who's asking for some clarification on a meeting of sodium channel issues.
I'm sorry, cut out again.
Sure. Sodium channel issues. Can you provide a definition for that?
So the question is questions about sodium channel?
Yes, sodium channel issues you had mentioned, and someone wanted you to offer some clarity on what that is.
So sodium is part of salt, or sodium chloride is table salt. So the sodium portion, some people might be familiar with the Na as the symbol for sodium. And sodium is important for a lot of biological functions within the body or within the cell. There are certain, and the way sodium gets in and out of a cell, or even in a cell, sometimes goes from one part of a cell to another cell, is through these things called channels, almost like a tube, if you will. And that will open and close depending on the situation and the needs of the cell. There are types of genetic changes that can cause problems or defects within these channels, whether they be sodium or other types of channels. And in the sodium channel, that could cause maybe it'll be leaky, too much sodium will come in, or maybe it won't open and therefore sort of block the sodium from coming in, or what they call gain of function or loss of function. And these changes in sodium function could cause all kinds of problems. One problem that they're highly associated with in certain types of sodium channels is epilepsy. Particularly, may have heard of SCN1A I mentioned before, a particular form of epilepsy called Dravet syndrome, which is a very severe form of epilepsy, and often seen in the pediatric population. Well, not often, but can be seen in the pediatric population. Often it can present as a febrile seizure and be misdiagnosed as a febrile seizure, but then they usually develop more findings. And they have a genetic variation that causes in the gene called SCN1A, which causes a problem within a certain type of sodium channel. So now we have a biological cause. Now the question is, can we modify the function of that channel to then cause treatments for epilepsy? And on the other hand, like I mentioned, some seizure medicines function by blocking sodium channels. So in somebody who has SCN1A, those type of medications can make things a lot worse. So there are certain medications that may be that you need to avoid when you have certain genetic variation findings. But there are other types of sodium channel or other sodium channel genes, if you will. SCN, STN means sodium channel, and then they're labeled by different numbers like 1A, and that might be 1B, and that might be 9A, and other types. And again, we're getting into this age where we could determine this by assessing someone's genetics, and that might then inform not just what might be the cause of the person's epilepsy, but also might have a big impact on how to manage that epilepsy.
Well, thank you again. And on behalf of the Family Support Center of New Jersey, Autism Family Services of New Jersey, and the Center for Neurological and Neurodevelopmental Health, also known as CNNH, we want to thank everyone for joining us this afternoon. Dr. Mentz, we greatly appreciate your time, and reach us at the Family Support Center of New Jersey at 732-528-8080. And Dr. Mentz, I know that the autism research study information is still on the screen, and I would encourage anyone to reach out to the number on the screen specifically if you have questions surrounding that study. So, Dr. Mentz, thank you very much. Again, it's greatly appreciated, and I wish everyone a great day. Thank you.
Thank you.